last talk is Chris Ryerson from Vancouver, and he's going to speak on unclassifiable ILDs.
Sorry, Marvin. Marvin asked me to not speak while I was here this week, so I'm going to disappoint him here. I'd first like to thank Luca and the organizers for allowing me to talk today, but I'm not happy about being between all of you and lunch, so I'm just as hungry as you, and we'll try to wrap this up quick. So this is work that I started while I was at UCSF a couple years ago, and I've since come back to Vancouver, but what I'm going to show you is all from UCSF patients. My disclosures for Intermune. The quick background on this is that some patients, as all of us clinicians are aware, we can't classify confidently with a specific ILD subtype. And there are a number of reasons for this, but they basically boil down to two main categories. And those are patients where there are non-specific or conflicting clinical, radiological, or histopathological features. So usually these are patients where the radiologist and pathologist can't agree, and we're not confident enough to be a tiebreaker. And then there are also patients where we can't, or they're unwilling to undergo a diagnostic procedure. And these patients we call unclassifiable ILD. The ATS-ERS statement from 2002 did mention this population and basically provided the same kind of background as I just did. And then went on to say that the concept of unclassifiable ILD was not intended to create an entity for clinical studies to arise, but to emphasize that there was a requirement for adequate clinical, radiologic, and pathologic information for classification. So we had three main objectives to look at this, and there really hasn't been any work in unclassifiable ILD that I was aware of. So this is pretty high-level, basic approach to unclassifiable ILD, and we wanted to determine the prevalence of and reasons for unclassifiable ILD, determine the characteristics and outcomes of these patients, and finally to investigate whether there were subgroups of patients that could be easily identifiable to have a distinct and predictable prognosis. So this was retrospective. All patients with unclassifiable ILD in the UCSF ILD database between the years 2000 and 2011. Most of the database is collected prospectively. So all the demographics, smoking history, exposures, PFT data, et cetera. And then there is retrospective chart review for some data, which you'll see as we go through this. And then we did have a retrospective and standardized reevaluation of all HRCTs that were available for these patients. Right off the bat, we excluded about 39 patients from the cohort, which represented about 3% of our population. And these were patients that had a potentially diagnostic test recommended by us, but when they were sent back to their referring physician, we never got any information about whether this test was performed or the results of that test. So we didn't have sufficient data to look at that group. We defined unclassifiable ILD if we were not able to come up with a specific diagnosis following multidisciplinary discussion. And we use standard criteria where available. So for example, for IPF, we would use the ATS-ERS statement. For other diagnoses, we required a level of diagnostic certainty that would allow us to confidently label a patient with a given ILD and to proceed with therapy for that disease without further evaluation. And this is something that's pretty subjective, and we think it applies to our population, but I think there is a limitation that other populations, other clinicians may have different thresholds for identifying patients with these diseases, so that is a slight limitation. We use some control groups, our fibrotic ILD population with IPF, idiopathic NSIP, connective tissue disease-related ILD, and hypersensitivity pneumonitis. We had a number of measurements at baseline, the standard variables, including HRCT, which we had radiologists blinded to clinical data who re-reviewed these and scored fibrosis score, identified a UIP pattern, and honeycombing. And the fibrosis score was done in the standard manner, as you see there. We also had some follow-up data, time to death or lung transplantation, and we also recorded FVC and DLCO 12 months after the baseline visit when available, which it was in about half of our patients. Statistics, just briefly, we compared unclassifiable patients to IPF and to non-IPF controls. We plan to use a competing risk regression, as Joyce Lee went over a couple days ago, but there actually were 0 transplants in our unclassifiable patients, so we really just did a Cox proportional hazards analysis. And then we define disease progression, as you see here, with a 10% decline in FVC, 15% decline in DLCO, lung transplantation, or death. And this is a brief flow sheet looking at how we got to our unclassifiable cohort. We had 1,370 patients, total ILD patients that met or that were potential for inclusion. And after excluding all of the defined ILD, we had 132 patients with unclassifiable ILD, which was 10% of our cohort. And that, you can see, slots in at the fourth most common diagnosis, if you will, behind IPF, HP, and sarcoid. The patient characteristics were what you'd expect to see in a group of ILD patients in general. So moderate physiologic impairment, I would say. About 20% were on oxygen. If we compare this to IPF and non-IPF controls, we see that the unclassifiable patients generally were intermediate between these two. So age slightly less than IPF, slightly higher than the non-IPF population, intermediate smoking history, intermediate use of oxygen. And the point of this isn't to illustrate, or isn't to suggest that this is a different population compared to these other two, but more to illustrate that it falls in between and is certainly a mixture of these two populations. We had two main reasons for patients being called unclassifiable when we went back through the data. And as I said, the first was whether we had conflicting clinical, radiologic, and histopathologic data, and that was about 1 in 5 patients. And then the other 4 categories really boils down to inefficient or insufficient tissue to provide a diagnosis. So in many of these cases, it was the provider, the physician saying that the risk of a biopsy was too high due to the patient being old or frail for other reasons. Some patients had mild or stable disease, in which case we felt that the biopsy was not justified because it wouldn't change management. And there were some patients that refused to undergo a biopsy. And we had some patients that had a biopsy but had insufficient tissue. The differential diagnosis illustrates that these patients did have a fibrotic ILD. So chronic hypersensitivity pneumonitis was the most common differential, IPF the next most, and then NSIP and connective tissue disease. So really these are patients that did have a fibrotic, unclassifiable ILD in general. The outcomes of these patients were again intermediate between the non-IPF and the IPF cohort. If we look at the actual hazard ratio, unadjusted or adjusted, there's not much difference. We adjusted for age, gender, FVC, and DLCO, which we know is important. There are prognostic factors in IPF, and there was no difference really with or without adjustment in the hazard ratios. Comparing unclassifiable ILD to IPF, which unclassifiable ILD does better, or compared to non-IPF, in which case unclassifiable does worse. We had 12 months progression data in about half of patients, as I said, and about half of our unclassifiable ILD patients met those criteria for progression. And again, this is slightly less than the IPF cohort and slightly more than the non-IPF cohort, although we didn't have numbers to be statistically significant there. And then the predictors of time to death on bivariate analysis are really what you'd expect to see. So measures of severity in general, and then other variables that are more in keeping with the diagnosis of IPF. Notable exceptions here, age and gender, were not on this list, but there was a trend to older individuals and males to have worse prognosis as well in the unclassifiable cohort. And multivariate analysis, and this was done in a number of different ways, and it didn't really matter which statistical manner we got to the end here, but DLCO and fibrosis score were the 2 independent predictors of time to death, with a really good C statistic. So this was a pretty accurate prognostic model just with these 2 variables. And disease progression had the same 2 variables in them as well. And again, area under the ROC curve was very high, or quite high at least. If we dichotomize these, just to illustrate these two variables, DLCO I dichotomized at 35%, and you can see there's a very wide split of the survival curves with a substantially high hazard ratio of almost 9. For fibrosis score, we dichotomized this at the median value for fibrosis score in our cohort, which was 20%, and again, a pretty reasonable split in the survival curves. with a hazard ratio of 3. And if we combine these two, so the top curve here, the top curve is patients with a high DLCO and a low fibrosis score. The next curve down is patients with one or the other of those being more abnormal, so a low DLCO or a high fibrosis score. And then the bottom curve with low DLCO and a high fibrosis score, showing that these two variables can be used pretty simply to illustrate who has a very poor prognosis. So in conclusion, unclassifiable ILD represents about 10% of a large, well-defined ILD cohort. And in our cohort, this is the fourth most common diagnosis behind IPF, HP, and sarcoid, although this, of course, would be different in different cohorts potentially. We showed that unclassifiable ILD is associated with clinical features and a prognosis intermediate between IPF and other fibrotic ILDs. And the risk of death or disease progression aligns closely with features suggestive of IPF. So these would be things like a radiologic pattern of UIP or possible UIP, HRCT fibrosis score, and presence of honeycombing. So that's all. I'd like to acknowledge Hal, who was instrumental in this, and also Tom Urbania, who reread all of the CTs for us and did a lot of work on that as well. So thank you.
Time for several questions.
Thanks.
Next.
So unclassifiable IPF is what you say you can't make the in other words, either you or Hal can make the diagnosis.
Talmadge too.
but he's usually too busy to even look. So I want to ask two questions. You know, the pathologists use a term when they have tissue and they can't classify it. They call it, at least at our place, uncharacterized pulmonary fibrosis. And our impression, without impressive data like you have, is that they kind of act more like IPF. So what do you do with the patients where you have pathology and it comes back as uncharacterized? In other words, they can't make it a UIP or NSIP. What do you do with those patients? I mean, in terms of your classification.
So I think in general, those patients would probably fall into this category unless there was some kind of smoking gun, if they live with a bird, or if, if they live with a bird with a CT scan that would be consistent with HP and we have that pathology pattern, then we might be confident enough to call them HP. And if we're not confident enough to give them a specific diagnosis, we generally would make our best guess and treat them as such.
And my second question is that on your radiographic features, you did have honeycombing down. Why didn't you call those IPF if they had honeycombing?
Right.
Was it atypical honeycombing?
So it would have been atypical. So for
Upper
example,
lobe or
potentially upper lobe or a lot of mosaicism, something that just led us away from a diagnosis of idiopathic UIP or IPF.
And were you struck by the fact that I think it was 53% of your patients were women?
Not particularly. I think the numbers are skewed a little bit by there being a number of connective tissue disease patients potentially in the differential diagnosis, so I think that explains that a little bit at least.
Gisli?
Yeah, so two questions. One, firstly, what did you do differently when you had them as unclassifiable? Did it change your management or did you manage them as IPF?
It depended. These people wouldn't have been suitable for a clinical trial, so we wouldn't have treated them in that way for IPF. Otherwise, it depended really on the diagnostic certainty, and so we don't, up here we didn't have the data to say whether we were 90% certain of a diagnosis of HP, and if we were 90% certain, we would certainly treat that person as though they had HP, but there were some people that we're probably much more uncertain about, and in that case, it really would be dealer's choice, and whoever was treating them would make that decision. But there was no standard approach to treating these guys.
So, and my second question is, when you did your predictors of time to death and progression, did you do the same analysis for your IPF? And because I kind of figure that you'll get the same answer for your unclassifiable and your IPF?
Yeah, so I didn't do exactly the same, and two main reasons. One, we'd just used that same cohort to publish the GAP staging system, the GAP index. So we'd already done much of that work. And second, we didn't have all of the radiologic variables for our IPF patients, so I couldn't repeat the exact analysis.
So I guess what I'm leading up to, is it more important to do a transfer factor and get a number than a biopsy and give it a name? I mean, that's the kind of question.
Yeah, I think that's something that we're working on as well, and that I think, you know, the diagnosis obviously matters, but the disease severity matters probably just as much.
We have a question over here.
Two
then
quick
Moises.
questions. The first question is whether you are aware of any familial aggregation of cases like this. Because we recently saw two ladies in their 65s, 70s. They had a catastrophic disease course. For a number of reasons, it wasn't possible to do the biopsy. And even the autopsy studies in one of these ladies, even with the autopsy, we were not able to have a final diagnosis.
Yeah.
And the second question is, and strangely enough, these two ladies passed away a few months apart. The second is one of these ladies' daughter, who is 50, came yesterday to see me asking me what to do. I mean, she's completely asymptomatic. Lung function test is completely normal. She wanted to have a chest x-ray, which is normal. Lifelong non-smoker. I told her to keep the bar very low in terms of symptoms like dyspnea, to have lung function test once a year, and to avoid any exposure, drugs, environment, what else? Thank you.
So your first question about the possibility of familial fibrosis being some of our patients, and we don't collect that data very rigorously when we do. We ask patients to say yes or no, do they have a family history of lung fibrosis, and I don't think that data is really reliable enough for us to make any big deal about, and I actually didn't look at that myself, but certainly there would be some patients in this group expected to have a family history if we did go back and look in detail. Your second question about what to do with that patient, I think what you say is reasonable, and that patient could be followed up longitudinally, and I don't think we would really do anything too differently from what you're saying.
Okay, Moises, then Professor Fabry, and then Kevin Brown.
Do these patients have bronchoalveolar lavage?
In general, no. Some of them would have, but generally no. And if they did have it performed, it would have been performed usually by the referring physician and not in a kind of standardized format.
Okay, because when we have this kind of patients, we usually make bronchoalveolar lavage.
Yeah.
And if the bronchoalveolar lavage is, there is an increase in lymphocytes,
Right.
we use corticosteroid or immunosuppressive drug at least for 6 months to see the response. And if it is macrophages, we do nothing.
Yeah, I agree. That's something.
Professor Fabry?
What was the pattern of comorbidities different in the three groups?
That's another area that we don't have great data on. So we didn't look at that specifically. We, again, ask patients to volunteer the presence of any comorbidities, and that's what we put in our database. We also have, obviously, the physician going through the history, but that's not standardized in any way, and I don't think our data is such that we can really go and look at those questions.
And the incidence of exacerbation during the follow-up?
That's another limitation of our database. Many of these, almost all of these patients are referred for a one-time assessment, and they may come back, especially if they're in a clinical trial, but generally they come for a one-time assessment and then they disappear back to their referring physician. So we don't have great longitudinal data to see what happens to these people over time, other than survival.
Kevin?
So I've got a comment, concept, and a question. So the comment is, so I find it interesting that the predictors of outcome were identical to what we see as highly predictive in IPF, right? So extent of disease in CT scan and DLCO, which puts them in that fibrosing lung disease category. But the concept is, you know, a lot of these studies are dependent upon the pretest probability of any diagnosis given the group of patients that you are historically used to seeing and the diagnoses that you are used to dealing with.
Yep.
And one of the pieces that we struggle with is because this is a multidisciplinary concept and that the clinicians are frequently dealing with written information from the radiologist and the pathologist, that what you haven't captured is the pressure on the radiologist and the pathologist to come up with a name for the pattern that they see, recognizing whether it's for clinical care or for a study. One of the things I think that Kevin Flaherty's data has shown us, that particularly amongst community physicians who are trying to make a diagnosis, that the default is almost always IPF if there is some uncertainty in coming to a diagnosis. And so one of the ways in radiology that they've tried to overcome this is to give some level of confidence when they come up with a pattern, whether they're highly confident or whether they're less confident, recognizing that adds a level of complexity to the analysis. Is that something that you're able to do with this?
We certainly could do that prospectively. Retrospectively, I guess we could do that as well, but it would be challenging, I think, to go back through all of these patients. But I think that is something that is worthwhile exploring, and the level of certainty, at what level of certainty, you know, should we treat somebody with IPF drugs, if there were IPF drugs, but we haven't looked at that in the past.
Okay, we have a question from the other room, and then Professor Wells will have the last question. Having some audio problems in the other room.
Very interesting. Was there a difference in autoimmune profile between unclassifiable and IPF, or between unclassifiable who did well or who did badly?
We have autoimmune profile on some patients with unclassifiable ILD, and there was no ability to predict outcomes within unclassifiable ILD looking at that autoimmune profile. I didn't specifically compare that to connective tissue disease or to IPF.
Thank you.
One key factor is the degree to which you are prepared to challenge a biopsy diagnosis with other information. Mm-hmm. And I note with interest that your study started in 2001, an era in which the histological diagnosis was still considered the gold standard. So you're going back to these cases with confident diagnoses made when a biopsy is taken. We're now in an era where we challenge the histological diagnosis a lot more frequently. Mm-hmm. And I wonder to what extent the prevalence of unclassifiable disease might actually be understated by your study, drawn from an era in which the biopsy was the gold standard in part.
Right. That's a good point. I wasn't at UCSF, obviously, in the early 2000s, so I don't know exactly how their multidisciplinary discussion worked at that point. I imagine it has changed over time. So it is possible that the prevalence has changed. And I find myself in my own practice, I probably have more than 10% unclassifiable because I seem to have fewer patients willing to go for lung biopsy, and I may have a different threshold for sending patients for a lung biopsy I'm maybe more satisfied with a little bit more uncertainty than they were at UCSF. So it certainly would be different probably over time and probably center to center.
Different for surgical expertise, and different too if you've got a very proactive, challenging radiologist.
Right.
So I would say in our practice it's more like 20 to 25%.
Yeah, mine may be similar to that too.
Okay, we have one truly final question from the other room.
Thanks, Nick Kirani from Edinburgh. It's a quick question and a comment. The question is, if you just repeat again, I think you suggested that at least some, or maybe many of the patients with the unclassifiable disease you tended to treat. Did I catch that right? Or
sorry, say that.
May have been treated with immunomodulatory drugs. Did I catch that right?
So when patients came to us with that unclassifiable ILD diagnosis, about half of them had been treated with prednisone and about 10% had been on azathioprine. And our recommendations really varied depending upon our most likely diagnosis and the differential diagnosis. So I didn't record what treatments these people had going forward, just because we don't have great follow-up data to see whether our recommendations were followed through on. So I can't really address that question.
So the comment is that in Edinburgh we have a very similar cohort. We had a poster here. The numbers are very similar. We call the patients that you call unclassifiable, we've called probable IPF. They haven't had a biopsy, but they've got fibrosis on their CT score. Their median survival is almost exactly the same as your group of patients, but none of our patients are treated. So we don't treat them. We treat them as if they've got IPF.
Yeah.
It's just a comment for you.
Yeah, I think some of our patients we would be confident calling, or we would be okay calling probable IPF, but some of our patients also we would not put in that probable category either, and would be more likely to treat them as though they had idiopathic NSIP or possible HP. So.
Thank you.
All right, thank you.